Thank you for joining us for this segment of the Mental Health Series presented by Intelios, which includes the American Registry for Diagnostic Medical Sonography, ARDMS, the Alliance for Physician Certification and Advancement, APCA, and the Point-of-Care Ultrasound Certification Academy. Your mental health is just as important as your physical health, and even more so when you are in the middle of a crisis, dealing with new challenges and uncertainty. The well-being of our healthcare professionals is critically important to us, which is why we created this mental health series. We want to help take care of you so that you can take care of your patients, your friends, and loved ones.
Welcome to today's podcast, which is part of a mental health series brought to you by Intelios and its family of certification councils. This podcast is in collaboration with the Moral Injury of Healthcare. I'm your host, Tricia Turner, current chair of the ARDMS Council and director of the Diagnostic Medical Sonography program at South Hill School of Business and Technology in Pennsylvania. I'm joined today by our guest speaker, Wendy Dean, who is president, CEO, and co-founder of the Moral Injury of Healthcare, a nonprofit organization addressing the crisis of clinician distress. A psychiatrist by training, Dr. Dean left clinical medicine when generating revenue crowded out the patient-centered priorities in her practice. Her focus since has been on finding innovative ways to make medicine better for both patients and physicians, technologically, ethically, and systemically. Wendy, thank you so much for joining us today. We're excited to have you.
Tricia, it's a real pleasure to be here. I appreciate the opportunity.
Absolutely. So let's just get started. It was hard to be a clinician before COVID arrived. Can you give us a picture of what the challenges were?
Absolutely. I think whether you were an emergency room physician or a nurse or a technologist, a sonographer, a radiology tech, medicine has been hard for a long time. We're being asked to do more and more with less and less, and still making sure that our patients get what they need. And what that ends up doing is driving us to pursue quality metrics and productivity expectations, attend to the EMR, make sure our patients are happy, all doing it with reduced staff, with less autonomy and less latitude to do what we know our patients really need. So we were all being increasingly pulled away from focusing on patient care and more focusing on how to keep the business side of medicine healthy, which of course is critical. But it was almost driving us in a direction of that focusing on profits over patients. And what it ended up doing is causing a lot of clinicians distress. So if you looked at the numbers of distress in clinicians, for example, nurses, almost a third of nurses said before the pandemic that they were struggling with one or more symptoms of burnout. More than half of physicians said that they were. And so the pandemic arrived in the context of a system already struggling.
It seems that more and more medical professionals are experiencing those pressures from all over, not just worrying about our patient anymore. Seems like we're worrying about so much more. So what is moral injury, and can you relate it to the medical professional?
Moral injury is a reframing of the concept of clinician distress. We've talked about the concept of burnout for the past 10 years. And even though we've tried, we meaning lots and lots of healthcare systems, have tried different approaches to addressing burnout, which is a constellation of exhaustion, feeling like you're ineffective, and being cynical or detached from your patients, nothing really has worked. So a colleague and I, Simon Talbot, thought about what might be a different way to approach distress. What is at the heart of it? And we came on this concept of moral injury, which is borrowed from a concept that was applied to combat veterans, but it seems appropriate in healthcare as well. And it's perpetrating, failing to prevent, bearing witness to, or learning about acts that transgress deeply held moral beliefs and expectations. And in healthcare, those deeply held moral beliefs and expectations are the oaths that we took to put our patients first, always.
Mm-hmm.
And so when we're in a position where we have to choose something other than our patients as our priority, that's when we start to struggle with, are we being true to ourselves? Are we being true to this promise that we made to take care of our patients as our primary concern?
Oh my goodness, that is clear. And we do use that term burnout, I would say, kind of loosely. And maybe you could give a little bit more insight to how moral injury is related to burnout, or how they're actually different from one another. Because again, we use that term burnout so easily in describing some frustrations that maybe don't align with what you initially described as detachment, not engaged, with our patients.
Absolutely. Burnout has become ubiquitous. We all use it. We all throw it around in kind of a loose way. And I think it's because it does cover a lot of territory. But the distress that most people are feeling is more than just working too hard, seeing too many patients, not getting enough sleep, not getting enough rest, not having enough breaks. When we talk about the relationship between moral injury and burnout, what I would say is burnout is a real thing. People really do struggle with this deep, profound exhaustion with how they're working. But there are a lot of ways to get there. What we have found, though, is that kind of the highway to get to burnout is moral injury. That when we go to work day after day, week after week, month after month, and we know we have to fight just to get what we know our patients need, that's exhausting. And when we consistently can't get our patients what they need, it feels like we're ineffective, like we can't do our jobs well.
Yeah, it starts to hurt.
Exactly. And then as that happens over time, we start to withdraw from our patients, and we stop investing in our patients because it's so painful to watch them not get what they need. So if we don't attach to them, if we don't empathize with them as much, it doesn't hurt us as much when they're in pain. But it also doesn't feel good to us to do that.
Oh, absolutely.
Yeah, that's part of why we went into this, is to take good care of our patients.
Exactly. And I can completely see how in the world of sonography, for example, something as simple as, maintaining your schedule and having only 30 minutes, 20 minutes to meet and perform the scan and interpret the worksheet for our physicians, that stress piles up and we don't know what to do about it, and we ask, and we're kind of battling that side of things, and how that can really just build up over time, for sure.
Absolutely. I mean, you're facing the question of, do I take the extra 5 minutes that my patient needs for good care, whether that's to reassure them, to explain the study to them, to do an extra view, or do I stay to my rigid schedule and not attend to my patient's needs? That's exactly the crux of moral injury. I know what my patient needs, and this external framework that I have no control over is tying my hands.
Well put. My goodness. So how do you see that the pandemic has impacted clinician distress? And what are some of the main concerns clinicians are sharing with your organization?
The pandemic has added an acute stressor on a chronic stressor. So people were already stressed with how they were being asked to care for patients, but that challenge has ratcheted up as staff, stuff, and space has become even tighter. As our patient volumes have gone up, our acuity has skyrocketed in the places where the pandemic has become a hotspot. And those stressors are intensified if clinicians don't feel like their leadership is sufficiently supporting them, if they're not explaining the PPE situation, if they're not giving them good information about what they're doing to combat the risks, to keep their workforce safe, if they're unable to bring in extra staff, if they're unable to sufficiently retrofit or expand their patient care areas. In all those situations, folks are facing increasing challenges with constrained resources. And then in the worst hotspots, when clinicians are facing the challenge of how do I allocate resources that are nearly gone? How do I make the choice about who gets a ventilator? How do I make the choice about, does somebody need a CAT scan or do they not? Those types of acute stressors are things that in US healthcare we have never talked about. They're almost, it's akin to rationing, and we are not skilled in having those conversations. We're not used to having those conversations, and that provides an increased level of intensity to that challenge of moral distress. How do I make the decision about which patient gets what care?
That is obviously extraordinarily stressful. I can only imagine for the physicians out there managing patients that, one, have COVID or not, and just trying to manage their patients in a time that we're seeing such an infectious disease run rampant. I'm interested in learning about the leadership. And are you hearing from any leaders in the medical communities, not only just the physicians, but maybe CEOs and the business side of the organizations? Are you hearing from any of them? And what is their conversation with you? And how are you helping spread this message of moral injury?
We're hearing that leadership knows their people are struggling. They know that people are facing challenges they've never faced before. They are trying very hard to provide the supports that folks need, but they're also caught in their own challenge because they're facing these increased needs at the same time they're seeing financial crises like they've never seen in healthcare. So at the same time, the frontline workers need support for psychological recovery and more staff and more stuff. The hospitals don't have revenue from elective procedures. So they're also caught, and they're facing their own challenge of moral injury. I know my folks need PPE, but if I shut down elective procedures, my institution might not survive this pandemic financially. And so the challenge is working together with clinicians and leadership to try to thread that needle between those difficult decisions. And I would also say that one of the struggles they're having is trying to understand how to bring patients in for maybe not routine care, but for diagnostic testing. They don't have COVID, but they may have another condition that needs attention. How do they safely bring patients in and continue the not emergent healthcare that's critical? How do they keep sonographers and radiology techs and radiologists safe? How do they keep their patients safe? Again, walking those very fine lines is challenging, and they're looking for ideas in all of those areas.
Right, and we want to make sure as medical professionals we are there for every patient that needs us, not just a certain category at a certain period of time. It's not like you can ignore somebody just because we have this infectious disease. We have patients that need our assistance that don't have COVID. So absolutely, and I can completely see the struggle and really appreciate your insight and illustration of moral injury and what that's doing and how it's termed and how it relates to burnout. And with that, we are just about out of time. Is there anything that you would like to add in clarification and enlighten us with more information regarding moral injury or burnout in your experiences?
Well, I think the easiest thing for folks to do if they need more information about it is to go to our website, which is fixmoralinjury.org, and they could contact us there. There's a contact page, and there's a wealth of resources, both media, articles, all kinds of things. So we'd welcome folks to come and take a look.
Oh, that's perfect. And that's great that they can share with their administrators for sure. Take this information to them. Wendy, thank you so much for being on today's podcast and giving us insight into the topic of moral injury and what healthcare workers are experiencing today.
It's been my pleasure. Thank you.
And we're so excited to have you speak with us again on the next podcast when we'll continue the conversation and focus on how we can support practitioners' psychological readiness and recovery going forward. So until the next podcast, I'm your host, Tricia Turner, signing off for now. Thank you for listening. Goodbye.
Thank you for participating in this mental health series brought to you by Intelios and its family of certification councils. You will find additional resources at ARDMS.org, APCA.org, and POCUS.org. These resources are for informational purposes only and should not be used as a substitute for professional medical advice. We encourage you to reach out to your personal physician or medical provider if you have concerns or questions.